Why can one small tube of cerebrospinal fluid reveal some deeply hidden inborn errors of metabolism? It is 3 o'clock in the morning. A child is brought into the hospital ward. This is not his first seizure. Over the past few months, his parents have heard many possible explanations. Maybe it is epilepsy. Maybe it is developmental delay. Maybe it is cerebral palsy. Maybe it is the aftermath of encephalitis. But this time, something feels different. During the day, the child can still smile, but at night, his body suddenly stiffens. His eyes roll upward. It is as if some invisible force has locked him in place. The seizure may not look dramatic, but anyone watching can tell something is clearly wrong. And there is something even more puzzling. When he has a fever, the symptoms get worse. When he does not eat well, they get worse. When he does not sleep well, they get worse. Several anti-seizure medications have already been tried, but the response is never stable. Routine blood work gives no answer. The brain MRI does not point to one clear diagnosis. Standard metabolic screening in blood and urine does not catch a typical pattern either. Finally, the doctor suggests another test. A lumbar puncture, one tube of cerebrospinal fluid. For many parents, the moment they hear cerebrospinal fluid, their first reaction is fear. It does not feel as familiar as a blood draw or a urine sample, but in some inborn errors of metabolism, or IEMs, the problem may not show up clearly in the blood. It may not show up clearly in the urine either. The problem may be happening closer to the brain, inside the central nervous system, or in the transport system between the bloodstream and the brain. For example, glucose may not be getting into the brain. Folate may not be getting into the cerebrospinal fluid. Dopamine and serotonin may not be made properly. Certain amino acids inside the brain may be too high or too low. A mitochondrial energy problem may reveal its first clues inside the brain. Think of it this way. Blood is like the main road outside a crime scene. Urine is like the body's metabolic trash bag. But cerebrospinal fluid is more like a small water sample taken near the scene itself. It is not a brain biopsy. It cannot represent every corner of the brain, but it sits much closer to the central nervous system. That is why some clues may be invisible in blood, invisible in urine, but visible in cerebrospinal fluid. Chapter 1. What is genetic and metabolic testing in cerebrospinal fluid actually looking for? In simple terms, it is not just checking a few more things. It is asking very specific questions. Does the brain have enough fuel? Can neurotransmitters be made? Can folate get into the brain? Are amino acids building up abnormally? Is there too little of a critical raw material? Is mitochondrial energy production impaired? Is one metabolic pathway blocked? In clinical practice, commonly tested markers may include amino acids in cerebrospinal fluid, glucose in cerebrospinal fluid, lactate in cerebrospinal fluid, 5-MTHF in cerebrospinal fluid. That is an important form of folate inside the CSF. Doctors may also test CSF terines and neurotransmitter metabolites. For example, HVA, 5-HIAA, 3-OMD-MHPG. These names sound highly technical, but you can think of them as footprints left behind by the brain's metabolic system. HVA mainly helps doctors assess the dopamine pathway. 5-HIAA mainly helps doctors assess the serotonin pathway. Terins and 5-MTHF can help doctors evaluate certain cofactor pathways and folate-related pathways. In particular, HVA, 5-HIAA terines, and 5-MTHF are often interpreted together. That combination can be important when doctors are trying to distinguish BH4-related disorders. So, what is BH4? You can think of it as a small helper inside the brain's chemical factory. It takes part in the production of dopamine and serotonin. When BH4 is not working properly, a child may develop movement problems, seizures, developmental delay, or symptoms that are mistaken for cerebral palsy. But CSF results cannot be interpreted in isolation. Doctors also need to look at the basic CSF results: the cell count, protein, glucose, lactate, because infection, inflammation, and other neurologic conditions can also affect cerebrospinal fluid. So CSF testing is not simply doing more tests to feel reassured. It is more like a focused set of investigative tools. Its purpose is to help doctors ask, inside the brain, which metabolic pathway may be going wrong. But a lumbar puncture is not something doctors do casually. If a child is in shock, has unstable breathing, has not recovered after a seizure, has a significantly decreased level of consciousness, has abnormal pupils, has a bleeding disorder, has very low platelets, is taking anticoagulant medication, or has an infection at the puncture site, doctors will usually treat the urgent danger first. Only then will they decide whether a lumbar puncture is safe. Before a lumbar puncture, the most important first step is not to search for a metabolic disease. It is to make sure the child can safely undergo the procedure. Chapter 2. Why does the quality of a CSF sample matter so much? Because in CSF metabolic testing, a poor quality sample can ruin the answer. Neurotransmitters, paterins, and 5-MTHF are fragile molecules. If the collection order is wrong, if the sample is contaminated with blood, if it is not frozen quickly enough, or if the child was taking certain medications at the time, the results can be affected. For this kind of testing, sample handling is not just a technical detail, it is part of the diagnosis. And there is one detail that matters a great deal: medication. For example, levodopa, 5-hydroxytryptophan, antidepressants, monoamine oxidase inhibitors, valproate, certain anti-seizure medications, folic acid or folinic acid supplements. All of these can change CSF results. That is why doctors do not read the report by staring at one high arrow or one low arrow. First, they ask, how was this CSF sample collected? Was there blood contamination? Was blood drawn at the same time? Was the child actively having symptoms? Or had the child already stabilized? What medications were given before and after the lumbar puncture? These questions matter more than a parent trying to interpret one number that is a little high or a little low. Chapter 3. Amino acids in cerebrospinal fluid. Many inborn errors of metabolism, or IEMs, can affect amino acids. Some involve a problem in amino acid metabolism itself. Some involve a transport problem. Some are organic acidemias. Others are related to urea cycle disorders. Blood, urine, and cerebrospinal fluid can all provide clues. CSF amino acids can be understood as a small map of amino acids near the brain. It is not a brain biopsy, but it is liquid evidence from much closer to the brain. The first classic example is glycine encephalopathy. It is also called non-ketotic hyperglycinemia, or NKH. Under normal conditions, the body has a system for clearing excess glycine. If this system is impaired from birth, glycine can rise in both the blood and the cerebrospinal fluid. The problem is that inside the brain, glycine is not just an ordinary nutrient. It affects nerve signaling. If too much glycine builds up, it can overexcite neural networks. This may lead to difficult-to-control seizures and white matter injury. Children with this condition may show symptoms in the newborn period: sleepiness, low muscle tone, breathing pauses, severe, hard-to-control seizures. Later, they may also develop serious developmental problems. The key here is not to look only at blood glycine. Doctors need to look at plasma glycine, CSF glycine, and the ratio between CSF and plasma glycine. In other words, if glycine is high in the blood, is it also high near the brain? And if it is high near the brain, is it disproportionately high? That is the first line of reasoning with CSF. The second situation is more hidden. There is a glycine-related disorder that may not look obvious in the blood, but the CSF can leave a clue. It is related to the SLC6A9 gene. It is also called GlyT1 glycine transporter encephalopathy. This is not the classic problem where the glycine breakdown system is broken. It is a problem with glycine transport. In some children, CSF glycine is only mildly to moderately elevated, not as high as in classic NKH. Plasma glycine may be normal or only slightly elevated. These children may have low muscle tone in the newborn period, breathing difficulties, startle-like movements, joint contractures, severe developmental problems. This reminds doctors of one important truth. Sometimes blood alone cannot show what is happening inside the brain. The third situation is also easy to misread. A high glycine level does not automatically mean glycine encephalopathy. Propionic acidemia, methylmalonic acidemia, and isovaleric acidemia are organic acidemias that can also raise glycine. In that setting, glycine is more like a smoke alarm nearby. When the alarm goes off, it does not mean the fire started inside the alarm. Doctors still have to look back at the wider picture. Urine organic acids, blood acylcarnitines, blood gas, ketones, blood ammonia, and whether there is acidosis. The fourth important marker is serine. Serine may look like just one amino acid, but it is very important for the brain. It helps build cell membranes and myelin. It participates in folate-related pathways. It also affects nerve signaling. So serine is not just a small molecule. It is connected to brain development, neurotransmission, and myelin formation. When serine biosynthesis is impaired, CSF serine is usually low. In some children, CSF5M, THF, may also be low. But plasma serine may not always be clearly abnormal. That is why the CSF result can be especially valuable. Children with these disorders may develop microcephaly, difficult to control seizures, developmental delay, white matter abnormalities, spasticity, eye problems. Milder patients may not develop symptoms until childhood or even adulthood. They may present with seizures, behavioral problems, peripheral neuropathy, or unsteady walking. One important point about these disorders is that some patients may have a better course if L-serine treatment is started early. The fifth clue is asparagine. Asparagine synthetase deficiency can also leave a trace in CSF amino acids. Common features may include congenital or early onset microcephaly, severe developmental delay, low tone in the trunk, and later spasticity in the arms and legs. If CSF asparagine is low, that can help doctors distinguish it from some similar disorders. But CSF alone cannot make the diagnosis. Confirmation still requires AS/NS gene testing. In other words, in a child with severe microcephaly, seizures, and early onset encephalopathy, low CSF asparagine is a clue worth taking seriously. The sixth example is glutamine synthetase deficiency. It is extremely rare, but it clearly shows why CSF amino acids can matter. Glutamine synthetase is involved in ammonia handling, nitrogen transport, acid-base balance, and nervous system metabolism. In some severe cases, Glutamine is almost absent from serum, urine, and CSF. In early reports, some children had severe brain malformations, multi-organ failure, and even death in the newborn period. Later research showed that the clinical spectrum of GLUL-related disease is still expanding. Some variants can cause congenital glutamine deficiency and developmental and epileptic encephalopathy. The seventh important area is GABA metabolism. GABA is one of the brain's most important inhibitory signals. You can think of it as the braking system of the nervous system. If GABA transaminase is deficient, that braking system can become disrupted. The ABAT gene provides the instructions for making GABA transaminase. This enzyme helps break down GABA when it is no longer needed. If this step fails, too much GABA can accumulate. The neural network may fall out of balance. Elevated GABA in CSF, a GABA peak on MR spectroscopy, or related clues on metabolomics can all support doctors in looking in this direction. The eighth important area is vitamin B6-related epilepsy. On the surface, some children's seizures look like uncontrolled electrical activity in the brain. But deeper down, the problem may involve the active form of vitamin B6. That active form is called PLP. PLP is a cofactor for many amino acid metabolism enzymes and neurotransmitter synthesis enzymes. You can think of it as a key required for many metabolic reactions to run. PNPO deficiency affects the production of PLP. Children with this condition often develop severe seizures in the newborn period. Some children respond to treatment with pyridoxal phosphate or pyridoxine. In some cases, CSF neurotransmitters and amino acids may also be abnormal. But those findings are supporting evidence. Diagnosis still depends on genetic and other confirmatory evidence. There is another, more common B6 responsive epilepsy. It is called pyridoxine-dependent epilepsy. It is related to the ALDH7A1 gene. In this disorder, certain substances from lysine metabolism build up. These substances can trap PLP and make vitamin B6 ineffective. So even though the child has B6 in the body, the key reactions still cannot run properly. During diagnosis, doctors may check whether alpha-ASA and pipecolic acid are elevated in urine, plasma, and CSF. By this point, you can see the pattern. CSF amino acid testing is not just checking random numbers. It helps doctors ask, is there too much of one raw material inside the brain? Is there too little of another? Or is one metabolic route blocked? When a child has recurrent seizures, developmental regression, low muscle tone, abnormal movements, and routine testing still cannot explain why, one tube of CSF may not be the final answer, but it may be the first clue that leads doctors out of the fog. Chapter 4. Glucose in cerebrospinal fluid. There is a condition called GLUT1 deficiency. It is easy to miss, because a child's blood sugar may look completely normal. There is glucose in the blood, but the brain cannot use it properly. Why? Because before glucose can reach the brain, it has to cross the blood-brain barrier. GLUT1 works like a ferry. It carries glucose from the bloodstream into the brain. If there is a problem in the SLC2A1 gene, that ferry may be reduced, or it may not work properly. The result is this: blood sugar looks normal, but the brain is chronically short on fuel. A child may develop seizures very early in life. There may also be developmental delay, abnormal eye or head movements, unsteady walking, or sudden chorea-like movements. In some children, symptoms become more obvious after fasting, after exercise, after fatigue, or after an infection. That is why CSF glucose cannot be interpreted by itself. It must be compared with the blood glucose level taken at the same time. If the child's blood sugar is already low, then a low CSF glucose level is not surprising. What truly matters is a different pattern. The blood glucose is normal, but the CSF glucose is clearly low, or the ratio between CSF glucose and blood glucose is low. That is when doctors begin to think about GLUT1 deficiency. Why does this matter? Because this is one of the treatable neurometabolic disorders. Some patients can use a ketogenic diet to provide the brain with another fuel source: ketones. That is why early recognition is so important. Chapter 5. Lactate in cerebrospinal fluid. When many parents see a high lactate level, their first thought is, could this be mitochondrial disease? That possibility can be considered, but one lactate result alone cannot make the diagnosis. Many different situations can raise lactate: infection, low oxygen, shock, a recent seizure, delayed sample processing, a tourniquet left on too long. All of these can affect lactate results. And a normal lactate level does not completely rule out mitochondrial disease either. But in certain situations, CSF lactate can be very useful. For example, imagine a child who suddenly regresses after an infection, after fasting, after surgery, or after anesthesia. Skills the child already had begin to disappear. Muscle tone becomes abnormal. Swallowing gets worse. Eye movements become abnormal. There may even be breathing problems, seizures, or changes in consciousness. Then the MRI shows abnormalities in areas such as the basal ganglia, the brainstem, or the cerebellum. If blood lactate or CSF lactate is elevated in that setting, doctors become highly concerned about mitochondrial-related disease, including the Lee syndrome spectrum. So, how can we think about lactate? Think of it as smoke coming out of the brain's power plant. It cannot tell you exactly which machine has failed, but it warns doctors that the energy production chain may truly be in trouble. The brain uses a tremendous amount of energy. The basal ganglia, brainstem, and cerebellum are especially sensitive to energy failure. So when energy production breaks down, a child may develop loss of motor skills, abnormal muscle tone, difficulty swallowing, abnormal eye movements, breathing problems, seizures, or changes in consciousness. But CSF lactate is not a standalone diagnostic marker. It has to be interpreted together with blood lactate, pyruvate, blood gas results, MRI findings, genetic testing, and, when needed, enzyme studies or evidence of mitochondrial function. Chapter 6. 5-MTHF in cerebrospinal fluid. This is something many parents easily overlook. A normal blood folate level does not mean there is enough folate in the brain. 5-MTHF is an important form of folate inside the cerebrospinal fluid. In the brain, folate is not just a blood-building vitamin. It participates in neurotransmitter metabolism, myelin development, methylation, and the synthesis of DNA and RNA. If the brain does not have enough folate, a child may develop developmental regression, seizures, unsteady walking, movement disorders, behavioral changes, or even white matter abnormalities. One classic example is FOLR, one-related cerebral folate transport deficiency. You can think of FOLR1 as helping folate enter the cerebrospinal fluid and the central nervous system. If this pathway is impaired, folate in the blood may not be low, but 5-MTHF in the CSF may be clearly insufficient. This point is critical. Normal blood folate does not equal normal CSF5 MTHF. So if a child has progressive developmental regression, difficult to control seizures, movement disorders, or white matter abnormalities, a normal routine blood folate level does not rule out cerebral folate deficiency. But the reverse is also true. Low CSF5 MTHF does not automatically mean FOLR1 is the cause. There are many other possibilities. Folate receptor autoantibodies, severe MTHFR deficiency, DHFR deficiency, MTHFS deficiency, DHPR deficiency, severe mitochondrial disease, and certain medications that affect folate pathways. For example, methotrexate, sulfonamide medications, phenytoin, long-term valproate use. So low CSF5 MTHF is not a simple answer. It is a clue. Doctors need to combine antibody testing, genetic testing, medication history, and other metabolic markers to understand the real cause. There is one more warning that matters. Do not replace folinic acid with regular folic acid on your own. For FOLR1-related cerebral folate deficiency, or cerebral folate deficiency related to folate receptor autoantibodies, treatment choices must be made by a specialist. Because the question here is not simply whether there is enough folate in the blood. The question is whether folate is truly getting into the brain. Chapter 7. The brain's chemical signals. Many children are diagnosed with epilepsy, cerebral palsy, or developmental delay. But the real problem may not be that the brain structure is damaged. It may be that the brain's signaling system is not working properly. Let's begin with one key substance, BH4. Its full name is tetrahydrobiopterin. You can think of it as a small helper inside the brain's chemical factory. It is not the main character, but without it, several important production lines can get stuck. BH4 helps the body process phenylalanine. It also helps make the precursors of dopamine and the precursors of serotonin. In other words, when BH4 has a problem, a child may show two kinds of clues. One clue may appear in the blood, elevated phenylalanine. Another clue may appear in the brain, not enough dopamine or serotonin. Many people have heard of dopamine and serotonin, but they are not only related to mood, they are also involved in movement, muscle tone, sleep, development, and behavior. That is why these children may not look like they have a metabolic disease at all. They may be labeled as having cerebral palsy. They may be thought to have early onset Parkinson-like disease. They may present with dystonia. Or they may have seizures, developmental delay, or even psychiatric and behavioral symptoms. So what is CSF Serine testing actually looking at? In simple terms, it looks at intermediate products along the BH4 production line. When a factory shuts down, doctors do not only ask whether the final product is missing, they also ask which step in the middle has become blocked. In some children, both neopterin and biopterin are low. This may point toward a GTPCH1-related problem. In some children, neopterin is high and biopterin is low. This may suggest PTPS deficiency. In some children, both neopterin and biopterin are high. Doctors also have to consider a DHPR-related problem. When DHPR is affected, CSF5 MTHF may also be involved. That means the folate pathway in the brain can be affected too. Other special patterns may point doctors toward P, CD, or SRD-related conditions. Parents do not need to memorize all of these names. What matters most is this, CSF Serine. Testing helps doctors determine where the BH4 cofactor pathway may be blocked. And once the direction is clear, some children may respond to neurotransmitter precursors, BH4, or other targeted treatments. Chapter 8. Neurotransmitter metabolites in cerebrospinal fluid. Doctors usually do not simply measure dopamine directly in the CSF. More often, they look at the metabolic footprints dopamine and related chemicals leave behind. For example, HVA mainly reflects the dopamine pathway. 5-HIAA mainly reflects the serotonin pathway. MHPG reflects the norepinephrine-related pathway. And markers such as 3-OMD, LDOPA, and 5-HTP can help doctors see whether precursors are building up and whether the final products are being made. You can think of it as a production line. Raw materials are at the front. Enzymes are in the middle. Finished products come out at the end. If precursors pile up but the final products are low, that suggests a step in the middle may be blocked. The first example is tyrosine hydroxylase deficiency. Tyrosine hydroxylase is a key early gate in dopamine production. When this gate is blocked, the CSF pattern may show low HVA, a low HVA to 5-HIAA ratio. MHPG may also be low, but 5-HIAA is relatively normal. Serines are usually normal. Children with this condition may have dystonia, Parkinson-like slowing of movement, episodes of upward eye deviation, improvement after sleep, milder symptoms in the morning, worse symptoms later in the day. Some milder patients respond very well to low-dose levodopa. That is why this condition can be easily mistaken for cerebral palsy. But when a child who looks like cerebral palsy has clear day-to-day or morning-to-evening fluctuation, improves after sleep, or responds to low-dose levodopa, that is an important red flag. The second example is AADC deficiency. The AADC enzyme helps convert L-dopa into dopamine. It also converts 5-HTP into serotonin. When AADC is deficient, a very typical picture can appear. Precursors build up. Finished products cannot be made. In the CSF, doctors may see low HVA, low 5-HIAA, low MHPG, high LDOPA, high 5-HTP, high 3-OMD. A child may show symptoms from early infancy: low muscle tone, oculogyric crises, excessive sweating, nasal congestion, sleep problems, feeding difficulties, severe delay in motor development. These symptoms may look scattered, but when placed inside the neurotransmitter pathway, they begin to form one connected line. The third direction is BH4-related disease. If BH4 is deficient, both dopamine and serotonin pathways can be affected. So HVA and 5-HIAA may both be low. But doctors cannot interpret only those two markers. They also need to consider terans, 5-MTHF, phenylalanine, urine piterins, DHPR enzyme activity, and genetic testing. That is why in these disorders, HVA, 5-HIAA, terines, and 5-MTHF are often interpreted together. Doctors do not make the diagnosis by staring at one number. Chapter 9. How should a CSF report actually be read? When many parents first receive the report, the arrows are what scare them most. One high arrow, one low arrow. And suddenly, no one sleeps that night. But doctors are not really looking at the arrows alone. They are asking whether those arrows connect into a metabolic pathway. The following patterns can help you understand how doctors think through the report. Pattern 1. CSF glycine is high. Plasma glycine is also high, and the CSF to plasma ratio is abnormal. In this situation, doctors may think about glycine encephalopathy also known as non-ketotic hyperglycemia. But the next step is not to make the diagnosis immediately. Doctors first confirm whether blood was drawn at the same time, whether the CSF sample was contaminated with blood. Then they look at urine organic acids and acylcarnitines. And finally, they confirm the diagnosis with genetic testing or enzyme studies. Pattern 2. CSF glycine is mildly elevated, but blood glycine is normal. In this situation, doctors may consider SC6A9-related glycine transporter encephalopathy, but they also have to rule out other possibilities. Milder forms of NKH, cobalamin metabolism disorders, testing error, or secondary changes. Pattern 3. CSF serine is clearly low. This makes doctors think about serine biosynthesis defects. If the child also has microcephaly, seizures, white matter abnormalities, and developmental delay, this direction becomes even more important. The next steps may include plasma amino acid testing, related genetic testing, and specialist evaluation for L-serine treatment. Pattern 4. CSF asparagine is low, and the child also has congenital microcephaly and severe developmental delay. Doctors may think about ASNS-related disease, also called asparagine synthetase deficiency. But low CSF asparagine is still only a clue. It cannot make the diagnosis by itself. Genetic testing is still needed for confirmation. Pattern 5. CSF glucose is low, but the blood glucose taken at the same time is normal. This makes doctors strongly consider GLUT1 deficiency. However, they also need to rule out infection, inflammation, meningeal disease, low blood sugar, and changes after status epilepticus. Doctors then look at the CSF to blood glucose ratio. They compare it with the child's symptoms: early onset seizures, movement disorders, worsening after fasting or exercise. Then they may order SLC2A1 gene testing and evaluate whether a ketogenic diet is appropriate. Pattern 6. CSF lactate is high. The child has episodic regression, and the MRI shows abnormalities in the basal ganglia or brainstem. In this situation, doctors become concerned about mitochondrial disease, the Lee syndrome spectrum, or pyruvate metabolism disorders. But this still has to be interpreted together with blood lactate, pyruvate, blood gas results, MRI findings, genetic testing, and when needed, enzyme studies or functional testing. Pattern 7. CSF5 MTHF is low. This points toward cerebral folate deficiency. It may be related to FOLR1-associated cerebral folate transport deficiency. It may also be related to BH4 disorders, mitochondrial disease, medications, or immune factors. The next steps often include testing FOLR1, checking folate receptor autoantibodies, evaluating BH4-related markers, and having a specialist assess folinic acid treatment. Pattern 8. Both HVA and 5-HIAA are low, and purines are abnormal. This suggests that the dopamine and serotonin pathways may both be affected. Doctors may consider a problem with BH4 synthesis or BH4 recycling. They also look for secondary monoamine abnormalities. At this point, they also need to review phenylalanine, urine pterins, blood pterins, DHPR, 5-MTHF, the medication background, and genetic results. Pattern HVA is low. 5-HIAA is relatively normal. Purines are normal. This pattern makes doctors think more about tyrosine hydroxylase deficiency, especially if the child has dystonia, early-onset Parkinson-like symptoms, improvement after sleep, or a response to levodopa. Pattern 10. HVA, 5-HIAA, and MHPG are all low, but LDOPA, 5-HTP, and 3-OMD are elevated. In this situation, doctors may consider AADC deficiency. If this is combined with oculogyric crises, sweating, nasal congestion, sleep problems, feeding difficulties, and severe motor developmental delay, then doctors have even more reason to investigate this pathway. So a CSF report is not something parents should use to guess a diagnosis on their own. One arrow does not explain the whole story. What truly matters is this: do the arrows connect? Do they point toward the same pathway? Does the child's clinical picture fit that pathway? Do the blood tests, urine tests, imaging, and genetic results line up with the same story? CSF metabolites are like footprints left behind by the brain. One footprint alone cannot prove who was there, but a trail of footprints may lead doctors back to the real scene. Chapter 10. What kinds of children should discuss CSF metabolic testing with their doctor? First, we need to be clear. Not every child with developmental delay needs a lumbar puncture. Not every child with seizures needs a lumbar puncture. Not every child with behavioral concerns needs a lumbar puncture. But if a child has repeated abnormalities that remain unexplained and standard treatment is not working well, it may be worth discussing with a pediatric neurologist or a metabolic genetics specialist. For example, a newborn or young infant with severe seizures, sleepiness, low muscle tone, breathing pauses, or a child whose seizures are difficult to control and who also has developmental regression, movement disorders, or episodes of upward eye deviation, or a child who looks like they may have cerebral palsy, but the course is unusual. They improve after sleep. They get worse after infection. They get worse with fatigue. They also get worse after fasting. That kind of fluctuation deserves attention. Some children may suddenly become weak when fasting, or first thing in the morning, or after exercise. They may become unsteady. Their movements may look choria-like. They may even have changes in consciousness. These should not simply be dismissed as poor stamina or a fragile constitution. If the brain MRI shows abnormalities in the white matter, basal ganglia, cerebellum or brainstem, and infection or a structural malformation does not explain it, neurometabolic disease should be considered. There is another situation. Blood and urine metabolic testing may not show a typical pattern, but the child's symptoms still remain highly suspicious. In that setting, CSF may provide clues from closer to the brain. For example, if blood phenylalanine is abnormal, doctors may need to distinguish a typical PAH deficiency from a BH4-related disorder. Or if blood folate is normal, but the child has progressive regression, seizures, movement disorders, or white matter abnormalities, it is not enough to simply say folate is normal. Family history also matters. If there has been unexplained infant death in the family, similar episodes in relatives, consanguinity, or multiple children with similar neurologic problems, doctors need to know that. Because CSF metabolites often do not hand doctors a disease name directly. They act more like a warning signal. Do not stop at epilepsy. Do not stop at cerebral palsy. Do not stop at slow development. Look one level deeper. Look into the metabolic pathways inside the brain. Chapter 11. After the report comes back, what should parents avoid doing? The most important thing is not to stare at one arrow and search the internet for a diagnosis. When a CSF report is abnormal, the real task is to line up the evidence. First, look at sample quality. Was there blood contamination? Was the sample frozen quickly? Was it collected in the required tube order? Was there any delay in processing? Second, look at the child's condition at the time of sampling. Did the child have a fever? Had the child been fasting? Had there just been a seizure? Was glucose given before the lumbar puncture? Were anti-seizure medications used? Was levodopa used? Were folate supplements used? All of these can affect the results. Third, pair the CSF result with blood testing. CSF glucose must be paired with blood glucose drawn at the same time. CSF glycine must be paired with plasma glycine. CSF serine is best interpreted with plasma amino acids. CSF lactate should be interpreted with blood lactate, blood gas results, and the sampling conditions. Fourth, additional blood and urine metabolic testing may be needed. For example, plasma amino acids, blood acylcarnitines, free and total carnitine, urine organic acids, urine orotic acid, homocysteine, methylmalonic acid, vitamin B12 related markers. These may all be needed. Fifth, genetic testing may be needed. This may be a gene panel, exome sequencing, whole genome sequencing, or it may require mitochondrial genome testing, copy number variant analysis, RNA analysis, or long-read sequencing. The choice depends on the clinical direction. Sixth, enzyme studies or functional studies may be needed. For example, DHPR enzyme activity, i.e. ADC enzyme activity, cell-based functional studies, RNA splicing analysis. Metabolites tell doctors which pathway may be blocked. Genes tell doctors where the blueprint may be written incorrectly. The clinical picture tells doctors whether this is truly happening in this child. When these three lines of evidence come together, the diagnosis becomes much stronger. Chapter 12. CSF testing does more than help doctors confirm known diseases. It is also helping scientists discover new neurometabolic disorders. Years ago, when doctors saw a child with seizures, regression, abnormal muscle tone, or behavioral changes, the available tests were limited. Blood glucose, blood ammonia, lactate, amino acids, urine organic acids, acylcarnitines. These tests could catch some classic disorders, but in some children the problem is deeper. The abnormality is happening mainly inside the brain. There may be only a faint shadow in the blood, and no clear trace in the urine. In that situation, CSF becomes extremely valuable because it is closer to the central nervous system. Older testing was like using a flashlight to look for footprints doctors already knew. If they suspected glycine encephalopathy, they measured glycine. If they suspected GLUT1 deficiency, they measured CSF glucose. If they suspected BH4 or neurotransmitter disorders, they measured HVA, 5-HIAA, taurines, and 5-MTHF. But now, metabolomics technology can scan many more small molecules at one time. Abnormal peaks, abnormal ratios, and abnormal pathways that no one noticed before may begin to appear. This is important for IEM research, because metabolites are closer to the chemical changes that are actually happening during disease. They help scientists ask, is a new pathway blocked? Is a gene variant causing this abnormal pattern? Can the same pattern be reproduced in cells or animal models? Is there a way to replace what is missing? Reduce a toxic buildup? Bypass the blocked pathway? Or even develop a new treatment? This is especially important in diseases of the central nervous system. Doctors cannot simply remove a piece of brain tissue to see whether a treatment is working. So, metabolites in CSF may sometimes become a roadmap for treatment monitoring. They can help doctors ask, is the medication reaching the central nervous system? Is the abnormal pathway moving back toward normal? Is the treatment hitting the real metabolic problem? Of course, seeing one abnormal peak does not mean a new disease has been discovered. Seeing one metabolite go up does not mean there is already a treatment. The path to reliable knowledge is long. Multiple patients need similar patterns. The genetic evidence has to fit. Cell or animal studies need to reproduce the finding. The clinical picture has to make sense. And eventually, treatment research and clinical trials are needed. So today, CSF metabolomics is more like an expanding map. It is promising, but not every hospital can use it as a routine diagnostic tool. Still, the direction is clear. In the past, many children were trapped under vague labels: possible cerebral palsy, refractory epilepsy, unexplained developmental regression, regressive autism, probably genetic, but still undiagnosed. Now, CSF testing and metabolomics give doctors and scientists a chance to look deeper, not just to describe symptoms, but to trace what is happening inside the brain, which fuel is missing, which toxic intermediate is building up, which neurotransmitter pathway has broken down, which gene-controlled metabolic route has gone wrong. That is the most forward-looking part of CSF testing. Today, it may help one child find the name of a known disease. Tomorrow, it may help scientists discover a disease no one recognized before. And further into the future, it may become a guidepost in drug development, a way to tell doctors whether treatment is truly reaching the real metabolic problem. CSF also opens some more specialized research windows. For example, trace elements and electrolytes. The brain is not simply soaking in blood. The blood-brain barrier, the blood-CSF barrier, CSF circulation, neurons, glial cells, mitochondria. All of these help regulate sodium, potassium, calcium, and magnesium. They also help regulate metal elements such as copper, manganese, zinc, and iron. Why does manganese tend to injure the basal ganglia? Why can abnormal copper transport affect development and movement? Do iron, zinc, copper, and manganese interact with one another? Routine blood tests may not be able to answer these questions. CSF metal testing currently belongs more to research settings or special clinical situations. It is not a first-line screening test for most IEMS. But it may help scientists understand why certain metabolic diseases damage the brain in specific ways. There is also CSF carnitine and CSF acylcarnitines. Carnitine and acylcarnitines in blood are important tools for evaluating fatty acid oxidation disorders and some organic acidemias. But carnitine and acylcarnitines inside CSF are currently more like supporting clues. They may be used in difficult neurometabolic cases or in research-based metabolomics. But their reference ranges and disease specificity are not as mature as blood testing. So remember this. Not every CSF test has the same level of maturity. Glucose, lactate, amino acids, 5-MTHF, Serines, neurotransmitter metabolites. These already have a recognized role in neurometabolic evaluation. But metal elements, acylcarnitines, and untargeted metabolomics are more often supplemental windows in special cases or research settings. They can provide clues, but in most cases they cannot diagnose a child's disease by themselves. Finally, let's return to the question we started with. What does one tube of cerebrospinal fluid really mean? A child with recurrent seizures may have epilepsy. A child with slow development may have many possible causes. A child whose eyes roll upward, whose body stiffens, and who improves after sleep may be mistaken for cerebral palsy, epilepsy, or unusual behavioral episodes. But if these symptoms happen again and again, and they come with developmental regression, movement disorders, worsening after fasting or infection, white matter or basal ganglia abnormalities, and poor response to standard treatment, then neurometabolic disease should be part of the differential diagnosis. Blood and urine metabolic testing can catch many IEMs, but CSF asks a different set of questions. Does the brain have enough glucose? Can folate get in? Are amino acids such as glycine, serine, asparagine, or glutamine abnormal? Has the dopamine or serotonin production chain broken down? Has a cofactor factory like BH4 stalled? Is mitochondrial energy production showing its weakness inside the central nervous system? Sometimes one tube of CSF will not immediately give the name of the disease, but it may lead doctors out of the fog of "it looks like epilepsy," "it looks like cerebral palsy," or "it looks like a psychiatric or behavioral problem," and bring them back to a specific metabolic pathway. For some treatable IEMs, finding that pathway may be the beginning of changing the child's course. This content is for medical education only. It cannot replace diagnosis or treatment by a physician. CSF testing is a specialized medical evaluation. Whether a lumbar puncture is needed, which tests should be ordered, and how medications should be handled before and after sampling must all be decided by qualified medical professionals.
If you are interested in inborn errors of metabolism, or IEMs, and in the connection between neurologic or psychiatric symptoms and inherited metabolic encephalopathies, you can find the full written version in the Shunyi series.